Thank you, Ashok. So this is a ultra low contrast PCI, and I purposely renamed it to zero contrast from zero contrast because I think we shouldn't be so dogmatic. The point here is to limit contrast utilization in patients who are at high risk of kidney injury. And I'm going to go through this both from a fundamentals point of view of why, but also how. So fundamental number one is that renalism is real. Renalism is essentially racism for people with CKD. And let me prove to you what renalism actually is. So I think we can all agree there's probably no better indication for coronary angiography than a heart attack. So here are patients who present with a myocardial infarction, and you can see that the patients who have CKD have a dramatic reduction in invasive coronary angiography compared to those patients with no CKD. And the reason for this is that very early in medical school, we're taught primum non nocere, don't do any harm. And so we think it's worse to put a patient on dialysis than it is for them to have a heart attack. And you might be right. So these patients are undertreated. Let's look at renalism in one of the most important contemporary trials in today's interventional cardiology. So this is ischemia trial on which I was an author, and I ran the angiographic correlab for. On the left side, you see the revascularization in the randomized invasive arm compared to conservative. And what you see is that 80% of patients who were randomized to revascularization actually got revascularized. Okay, so the ratio of revascularization to catheterization is about 83%. On the right side is exactly the same study, except these patients have CKD. There's no other difference in the protocol other than they don't get a CT. Now, even though you're randomized to get an invasive strategy and undergo PCI for coronary disease, only 50% get PCI. And the ratio of revascularization to catheterization is no better than a coin flip. Why does that happen? It happens because if you inject contrast, like it or not, into patients who are at high risk of developing renal disease, they go up on dialysis. So you can see in the invasive arm, acute kidney injury is dramatically higher, and dialysis is 3 times higher in this ischemia trial compared to not. On the right is work from CRF that we contributed. This is the ADAPT-DES study, and what's alarming here is you can see that patients who develop a contrast-associated acute kidney injury who have CKD do even worse than dialysis patients. So that's really hard to do because dialysis, as we all know, is probably one of the worst predictors of long-term outcome. Not all chronic kidney disease is the same. Now, in most trials, we use a cutoff of GFR of 60 as determined to be CKD. But the event rate actually dramatically goes up with a GFR of around 30. So we really need to start thinking about ultra-low contrast angiography and PCI in patients who have CKD levels 3B with diabetes or 4 with without diabetes. Now, you can see the benefits of PCI and non-ST elevation MI in CKD in every single group, 60 to 90, 45 to 60, and 30 to 45, but not in patients who have a GFR less than 30. That's interesting. So at first, you'd probably look at this and think, we should probably not be doing this. But actually, it's because we're doing it very poorly, and we're harming more people than we're actually helping. It's important to not put patients who have CKD onto dialysis. Look at this fact. A 25-year-old end-stage renal disease patient has the same annualized mortality as a 75-year-old in the general population. So putting a person on dialysis has profound implications not only on their lifestyle, but also on their mortality. Now, when you have a CKD patient, we've been taught to hydrate, hydrate, and hydrate. But I'm going to actually employ you in CKD stage 4 and 5 patients not to pre-hydrate. This is why. This is 100 consecutive patients who had ultra-low contrast angiography with a mean GFR of 20. And you can see that there's absolutely no correlation with what you think they have clinically and what their filling pressures are. So if you take this patient and pre-hydrate them with 2 liters of fluid, by the time they lay on the table, they'll be panting, they'll be in pulmonary edema, and you can significantly harm them. But if you don't pre-hydrate this patient, you're actually doing them a harm and increasing their risk of contrast-associated acute kidney injury. We all know this study by Somjit Brar, which showed the evidence for why we should do pre-hydration in patients with CKD. But notice that the mean eGFR in these patients is actually 48. That's pretty good. We're talking about the extreme risk patients. Now, let's all start using contrast hygiene. What does that mean? So in a patient with CKD, you should remove the contrast from the catheter between exchanges because every milliliter counts. There should be no contrast puffing for engagement. Why? We have better strategies. When you think you're engaged in the coronary artery, inject 10 milliliters of saline into the artery and you will see profound EKG changes. That's because of a combination of hemolysis and ischemia as well as the saline conducting electricity. But you know immediately based on these EKG changes that you're engaged. When you're doing a PCI, all you need to do is do the same trick with your EKG, but also use a workhorse wire. A workhorse wire enters the artery quickly and efficiently and is a very safe way to perform catheter engagement. What about optimized angiography? We need a target. And the way to optimize angiography is to limit your contrast volume to eGFR ratio to less than or equal to 1. And if your eGFR is less than 15, you should dilute your contrast and you only need 3 projections: AP cranial and AP caudal on the left and iliocranial on the right. The LV-EDP should be used for hydration. And then, if you have an ambiguous lesion, what you should be doing is using physiology. Here's an example of an ultra-low contrast eGFR. It's an ultrasound-guided groin access micropuncture. You just need to puncture above the bifurcation. You can safely close this. This patient's GFR is 13. The absolute contrast limit is 13. 1 shot of the right coronary artery and 2 shots of the left coronary artery. Give you as much detail as you need. Total contrast 9 mils. Don't do this, okay? This will make your life very difficult when you need to do a zero contrast PCI. This should be done on low magnification with absolutely no panning. This Philips technology, which has been in most of the cath labs that I've visited in India, is tremendously helpful. I'm pushing Philips very hard to actually try to get them to upload a previous angiogram as part of the dynamic roadmap. Siemens actually has the capability to do this with something called DynaCT, which co-registers a CT to the spine of the patient, allowing you to track the arteries in real time. What about during the intervention? Well, first of all, the intervention should typically be done as a staged procedure. You should do the diagnostic angiography, use your 10 milliliters, and then come back on another day to perform the PCI. Why? Because once we go past that contrast volume to eGFR ratio of 1, we have a logarithmic increase in contrast-associated acute kidney injury. So once you have your reference frame, you don't move the table. You perform live fluoroscopy, and what you try to do is use exaggerated curves on the wire, so when the wire enters the arteries, you have wire safety. And you'll see that in most of my ultra-low or zero contrast cases, I'm trying to create a loop on purpose very early because it's very difficult to push that out of the end of the coronary artery, and it's much safer. Once we've got wired, we don't move the table. The next step is actually to perform the MLD max guided approach with intravascular ultrasound. And the first thing we want to do is assess the plaque morphology. So all we're doing here is doing an IVUS guided pullback on the tram, And what we can see right away is that in the middle of this vessel, there's a dense segment of calcification. And so the morphology tells us that we need lesion preparation, which we perform. After pre-dilating, we also need to size by IVUS. And what we're doing is we're at the distal reference measuring the artery, creating a bookmark, scrolling through the lesion, which is now cracked, and finding a segment of artery where we're willing to land. So you can see here, I'm looking for a proximal reference. This is an area with a plaque burden of less than 50%, and I have everything that I need. I have the distal reference, I have the proximal reference, and I have the length. So I need an 18 millimeter stent. Now, how do I co-register this? The way I co-register this is when my IVUS marker is at the distal reference on the live IVUS, all I do is put my foot on the pedal, okay? Press Cine, record that spot co-registers to your IVUS, and then don't move the table. And you use your IVUS co-registration as your distal marker, and then you do your DS deployment in exactly that view without moving the table. We can also do our post-dilation using exactly the same strategy. We should use the MLD max approach. Your distal reference rounded down for the distal half of the stent, your proximal reference rounded down for the proximal stent. And then following this, all we need to do is do our post-PCI assessment, and that is to scroll in, look at the edge of the stent for any signs of edge dissection, measure the distal reference area, which is going to be our target, and then we're going to scroll through the artery for the minimal stent area and make one more measurement. So we're going to make one more measurement here. And of course, this divided by the distal reference area is going to be our expansion. So here, our distal reference was 3.6. Our minimal stent area is 3.3. We're 92% expanded. That's the end of the case. If you want to learn zero contrast PCI absolutely step by step, I would implore you all to join us on OPCI Live 2022. We have every step for both ultra-low contrast diagnostic procedures as well as PCI in a multiple different strategies and formats. So thank you very much.